Hi, I am Dr. Selvaraj, your surgical educator from Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical clerkship rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. Today, in this episode, I am going to start a new series of MCQ videos on acute abdomen. The first episode is on acute appendicitis. We are going to discuss 10 MCQs on acute appendicitis in this episode. So, regarding the MCQ, I don't think that I need any, explanation for the importance of the MCQ because both in your qualifying as well as in competitive medical entrance exams, you should face MCQ, especially for medical entrance exam. The whole exam is only MCQ. So you need not do any ASCII exam or clinical exam and all for medical entrance exams. Of course, for the qualifying, it is different, but MCQ is that important, and you should know how to tackle these MCQs. And this series of videos is a very good way to, it is a systemic way of revising the systematic way of revising the whole spectrum of general surgery, topic by topic. See, in this episode, I am going to discuss 10 MCQs exclusively on only acute appendicitis. Okay, but before going to discuss those MCQs, I want you to click this link and watch my videos in my YouTube Surgical Educator on acute appendicitis. Watch that video first, learn everything, and then come back to this video, and then we will discuss the 10 MCQs. Before going to the 10 MCQs, here I am sharing the acute appendicitis. Whatever I talked in that video for more than 30-40 minutes, everything is there. All the data are here in this single page. That is the beauty of mind map, a very powerful way of reviewing any topic. So you can just go through it. I'm not going through it. You just pause this video. You can, I think if you watch that video already, it is there. The same mind map is there in that video also. So now we are going to the MCQs one by one. MCQ number 1, a 22-year-old man present with periumbilical pain that migrates to the right lower quadrant over 12 hours. He has low-grade fever and anorexia. What is the most likely diagnosis? A. Acute pancreatitis. B. Gastroenteritis. C. Acute appendicitis. D. Renal colic. Of course, the correct answer is acute appendicitis because the classical presentation of appendicitis includes central abdominal pain that shifts to right lower quadrant pain along with fever and anorexia. So this is a classical history. Acute pancreatitis, in acute pancreatitis, this is incorrect because pain is usually epigastric and radiates to the back. Gastroenteritis usually involves diffuse pain and diarrhea. Renal colic, the pain radiates from the flank to the groin, not periumbilical to right lower quadrant. So reference is from Bailey and Love's 28th edition, chapter 60. Coming to MCQ number 2, a 30-year-old woman presents with right lower quadrant pain. On vaginal examination, cervical motion tenderness is noted. What is the most likely diagnosis? A. Acute appendicitis. B. Pelvic inflammatory disease. C. Ectopic pregnancy. D. Ovarian torsion. So, of course, the correct answer is B. Pelvic inflammatory disease. The cervical motion tenderness is characteristic of PID. If they are having very severe pain, okay, this is invariably PID. This is called Chandler's sign because the patient will have severe pain. They will raise both the upper limb and as if when they are raising the upper limb, it looks like as if they are going up with the hand to catch the Chandler there. This is what is called Chandler's sign. Acute appendicitis is wrong because it may mimic PID but does not cause cervical motion tenderness. The Chandler sign is negative in acute appendicitis. Pelvic inflammatory disease is the correct answer. Ectopic pregnancy ruled out with negative pregnancy tests or negative history of missed period. And then ovarian torsion, typically acute onset and very severe presentation, severe pain with adnexal tenderness also. So reference is from SWOT surgery 11th edition, chapter 30. Coming to MCQ 3, a 12-year-old boy present with right iliac fossa pain, vomiting, and fever. On examination, his SOVA sign is positive. What does this indicate? A. Urinary colic. B. Retrocecal appendicitis. C. Crohn's disease. D. Perforated duodenal ulcer. Of course, the correct answer is B. Retrocecal appendicitis. Because a positive SOVA sign, that is pain on extension of the right hip, suggests retrocecal position of the inflamed appendix. Urinary colic may cause flank pain, but no SOVA sign. Retrocecal appendicitis is the correct answer. Crohn's disease usually presents with chronic symptoms. It is not an acute problem. Perforated duodenal ulcer present with epigastric pain, not RIF tenderness, with, of course, rigidity also. Reference is Subsistent Textbook of Surgery, 21st edition. Coming to MCQ number 4. A patient present with suspected appendicitis. He has rebound tenderness at McBurney's point. What does this clinical sign represent? A. Visceral peritonitis. B. Somatic peritoneal irritation. C. Gastric ulcer. D. Omental infarction. Of course, the correct answer is B. Somatic peritoneal irritation. Rebound tenderness is a sign of parietal peritoneal inflammation, indicating localized peritonitis. Visceral peritonitis, visceral pain is dull and poorly localized. Okay, that is visceral pain. That is, initially the pain was periumbilical. That is because of the distension of the appendix. That is a visceral pain. So D is the correct answer. C and D, gastric ulcer and omental infarction, is not typical presentation with localized peritoneal signs. Reference Bailey and Love, 28th edition. Coming to MCQ number 5, a 40-year-old male has right lower quadrant pain for 2 days and a palpable mass is noted. He is afebrile and stable. What is the next best step? A. Immediate surgery. B. Intravenous antibiotics and interval appendectomy. C. Oral analgesic and observation. And D. Diagnostic laparoscopy. Of course, the correct answer is B. Intravenous antibiotics and you have to do interval appendectomy. A phlegmon or appendiceal mass or lump is best managed conservatively. That is our Asna Sarans regimen. You have to manage conservatively first, and nowadays here I have written interval appendectomy, but that is wrong. Interval appendectomy nowadays we are not doing. Only if patient is having a recurrence again, we have to advise them to come as early as possible. So we need not ask them to come for an interval appendectomy according to the latest Balian law. So immediate surgery increase risk of complication. So usually you have to do only conservative management. Oral analgesic and observation, this is inadequate without antibiotics. Diagnostic laparoscopy not required unless diagnosis is unclear. So reference is Sebastian 21st edition. Coming to MCQ number 6. A 28-year-old woman present with abdominal pain. Pregnancy test is positive. Ultrasound reveals a non-viable embryo in right fallopian tube. What is the diagnosis? A. Acute appendicitis. B. Ruptured ovarian cyst. C. Ectopic pregnancy. And D. Endometriosis. Diagnosis is quite obvious. So correct answer is of course C. Ectopic pregnancy. But it is unruptured fallopian pregnancy. Fallopian tube. Yeah. Because the pregnancy with pain and non-viable tubal embryo, that is ectopic pregnancy, which is a surgical emergency. It should be confirmed by the urine pregnancy test and ultrasound. Acute appendicitis is less likely with positive pregnancy test and history of missed period. Ruptured ovarian cyst doesn't explain embryo in the tube. Endometriosis, not an acute surgical cause, and endometriosis, the pain will be there only during menstrual period. Otherwise, there won't be any, pain in the abdomen. Reference is Davidson Medicine 24th edition. Coming to MCQ number 7. A patient has appendicitis with diffuse peritonitis and is already toxic. What is the most likely intraoperative finding? A. Appendicular phlegmon. B. Gangrenous perforated appendix. C. Mucocele of the appendix. D. Simple catarrhal appendicitis. The correct answer is of course B. Gangrenous perforated appendix. Explanation. Signs of sepsis and peritonitis indicate perforation with generalized contamination. Patient will be having rigidity also in this case. Appendicular phlegmon, it localized mass formation, that is the appendicular lump. Mucocele of the appendix usually doesn't cause acute peritonitis. Simple catarrhal appendicitis, this is early stage of the appendix. Patient won't be toxic. Reference is Quartz 11th edition, chapter 30. Coming to MCQ number 8. Which of the following is the most common position of the appendix? A. Retrocecal. B. Pelvic. C. Subhepatic. And D is pre-ileal. Of course, the correct answer is A. Retrocecal. Because retrocecal position is seen in, this is the commonest 60 to 65% of the patients. Retrocecal, that is the correct answer. Pelvic, next most common 30%. C and D, very less common variants. Reference Balian Law 28th edition, chapter 30. Coming to MCQ number 9. Which scoring system is most commonly used for clinical diagnosis of acute appendicitis? A. SOFA score. B. Alvarado score. C. Child-Pugh score. And D. Ranson's criteria. So among this, the correct thing is B. Alvarado scoring. Alvarado combines symptoms, signs, and lab values to predict appendicitis. So total score will be 10, and the mnemonic is Mantrals. SOFA score is sepsis-related score. Yeah, we are using it to find out the severity of the sepsis. That is SOFA score. Alvarado is the correct answer. Child Pew, C is for liver disease, how severe liver is affected, Child Pew. And Ranson's is for pancreatitis severity. So reference is again Sebastian, 21st edition. Coming to MCQ number 10, which is the first line imaging modality in suspected appendicitis in young adults? A. CT abdomen, B. BMR, and C. Diagnostic laparoscopy, and D is ultrasonography. The correct answer is D. Ultrasonography. Ultrasound is non-invasive, radiation-free, and useful, especially in young and pregnant patients. CT abdomen, more acute, but it is second-line investigation. And B is reserved for pregnancy. That is MRI scan. MRI scan is B. Yeah, that is for only during pregnancy, because CT we should not do, so you can go for MRI scan. C is diagnostic laparoscopy is used when diagnosis is uncertain or in operating theatre. Okay, you can do this. So reference is SWOT surgery, chapter 30. So these are all the reference book. The first two books are problem-oriented books. This is the best way to learn surgery. In all the textbooks, including Bailey and Love or Sebastian or whatever it is, they are teaching surgery system-wise, or the topic-wise, means appendix. They will discuss everything about appendicular disease. Okay, the area-wise or system-wise, they are teaching all these textbooks. But in this text, these two books, it is problem-oriented. They will discuss everything about acute right lower quadrant pain in one chapter. Acute right lower quadrant pain, one chapter. Acute right upper quadrant pain, another chapter. Like that, the main focus is the problem and not the individual disease. That is the way we are working in the clinic. We are not seeing cases randomly. So one group of problems, you have to know everything about that particular problem. What are the different causes? Everything. It is not just one system. That is the way you should learn surgery. This is the best way. That is what we are actually doing. And all other books are case-based scenarios. So nowadays, for all entrance exams, USMLE and UKMLE already they are using only case-based scenario questions, MCQ also. But in NEET PG and NEET SS also, FMG also, they are off late. They are using only case-based scenarios they are giving, and then they will ask the question, MCQ also. So it is not the theoretical recall question you are going to answer. Whatever knowledge you have to apply that knowledge in that particular case scenario, and you have to solve the problem. So this is the way it is going to be in future. And this link you can click and see what are all the different textbooks available to become a master surgeon. So you can click it and you can watch that video also. And this is my own book. I only created this book, and I am especially for my students in my institution. And I gave this book to it contains more than 120 case scenarios, 9 modules it have. So you have to, and I have shared this book freely to all my students. Here also for you also I am giving it free. You just click this link. You can download this book, 485 pages I think. So you can just go through this book. Very excellent book, very useful for your entrance exams. Or you can click this link of my YouTube channel and you can watch. I'll be discussing all the 9 modules clearly with each case scenario, and the answers also I am discussing. So please utilize this book. So thank you very much for watching this video. If you think that these videos are very useful to you, kindly share it in your social media and click this bell button also to get notified regarding my latest upload. So thank you very much once again for watching this video. If you think that okay, so let us meet once again in yet another episode. Until then, bye bye.